All right, let's jump right in. We're talking about venom allergies today, something that can show up in your clinic or ER with, some real urgency. This is a clinician's guide to managing them. So, whether you're dealing with this on the front lines or maybe you're prepping for your specialty exams, our goal here is to give you a super clear evidence-based path to follow, right from that first reaction all the way to long-term treatment.
But before we get started, I really want to give a huge shout out to Dr. Mohammed El-Nagi Mohammed. His expert guidance was it was absolutely key in putting all this content together. We really couldn't have done it without him, so thank you.
Okay, so here's how we're going to break it down. Think of it just like a clinical workflow. First, we'll figure out how to classify the reaction. Then we'll cover what to do in that acute phase. After that, we'll talk about who needs a referral for allergy testing, how to get patients set up for long-term management, and finally, we'll get into the big one, venom immunotherapy, or VIT. Okay, section 1, classifying these reactions. Look, first things first, we have to get the classification right. How a patient presents literally determines everything we do next. So figuring out if we're looking at a big but just local reaction versus something systemic or even anaphylaxis, that is absolutely the critical first step. So what are we actually looking for? What's the real difference? Well, a large local reaction can look pretty dramatic, right? We're talking redness and swelling that spreads out more than 10 centimeters. But, and this is the key, it's still stuck right there, around the sting site. The second you see symptoms showing up away from the sting, like hives all over or angioedema, that's when you know you've got a systemic reaction on your hands. That's the alarm bell telling you this isn't just local anymore. And listen, this next part is maybe the most important diagnostic point of all. The moment a patient has any sign of airway compromise, that throat swelling or tightness, or any signs of hemodynamic compromise like they're dizzy or their blood pressure is dropping, that is anaphylaxis. Full stop. It doesn't matter if they don't have a single hive. Remember your ABCs: airway, breathing, circulation. They always come first. Okay, so we've made the diagnosis. Now we're into acute management. When you're staring down anaphylaxis, your response has to be fast, it has to be confident, and you gotta stick to the protocol. Luckily, the protocol here is pretty straightforward, but there's no time to waste. Number 1, top of the list, the lifesaver, is intramuscular adrenaline. Everything else comes second. Once the adrenaline is in, then we can think about things like IV steroids and IV antihistamines to help calm down that inflammatory response. And of course, you're going to provide supportive care as needed. Oxygen, maybe some nebulized bronchodilators, whatever the patient's condition calls for. All right, the patient is stable. The immediate crisis is over. Now our job shifts, right? We're moving from emergency mode to thinking about the long term. We have to figure out who's at high risk for this happening again and who needs to see a specialist. So that's the big question, isn't it? Who actually needs allergy testing? Because it's not every single person who has a reaction. The indications are actually really specific. So here's your checklist. Any patient who's had a systemic reaction that involved their airway or caused hemodynamic instability, that's an automatic referral, no question. And then there's a special group, folks in high-risk jobs, like beekeepers. For them, even if they've only had a systemic skin reaction, you should still strongly consider a referral just because their chance of getting stung again is so high. Now we're moving into long-term management, and this is where our job really changes. We become educators. Giving the patient the right tools and knowledge to manage this themselves is absolutely essential to preventing another trip to the ER. Every single patient who's had a systemic reaction needs to walk out the door with 4 key things. This is non-negotiable. 1, a clear written action plan. 2, good training on how and when to use antihistamines. 3, really solid training on how to use their adrenaline autoinjector. And 4, a strong recommendation to wear a medical alert bracelet or necklace. That's the whole package that's going to empower them to take control if it happens again. And that brings us to our final section, and it's a big one. We're talking about the definitive treatment for these high-risk patients, venom immunotherapy, or VIT. For people with severe venom allergies, this isn't just a treatment, it's a total game changer. And I'm not exaggerating here. VIV is widely considered to be one of the single most effective immunotherapies we have, period. The impact it has on stopping future anaphylaxis is, it's just incredible. You don't have to take my word for it. The numbers really speak for themselves. I mean, look at this. For wasp sting allergies, we're talking a 95 to 100% success rate in preventing systemic reactions. For bee stings, it's still around 80%. These are just amazing numbers. Think about the peace of mind that gives a patient. It can literally change their entire life.
So, who gets this treatment? Well, there are two key criteria you have to meet. First, the patient needs to have that history of a severe reaction, one with airway or hemodynamic compromise. And second, and this is a big one, we have to prove that they have venom-specific IgE. We have to see it on a skin prick test or in their blood work. If you don't have that objective evidence, you can't do VIT. It's a hard and fast rule.
Here's a really important clinical pearl for you. Before you even think about starting VIT, you should always check a baseline tryptase level. Why? Because it's a screening test for an underlying mast cell disorder, like indolent mastocytosis. Finding that is a big deal because it can mean a higher risk of reactions during the therapy itself. So it's something you definitely need to look into.
The benefits of VIT go way beyond just the physical protection. Study after study shows this huge improvement in health-related quality of life. And that makes sense, right? We're not just stopping anaphylaxis. We are freeing people from the constant nagging fear that the next sting could be fatal. It's like lifting a massive weight off their shoulders.
So to wrap this all up, I want to leave you with a question to tit back to your own practice. Now that you know just how effective VI2 is and what a profound difference it makes in a patient's quality of life, what's one thing you can do starting tomorrow to get better at identifying and referring these at-risk patients? Because they're out there and they're waiting for this life-changing treatment.